Might I introduce Dr. Adelaide Robb, Professor of Psychiatry at the George Washington University? The podium is yours.
So we're going to talk about neuropsychological profiles and some testing in epilepsy, and it sort of builds on the talk that we heard previously from Dr. Guyard. So when do we think about neuropsychological profiles? One of them is in the impact of treatment. Are you having side effects from medications after surgery? We've already talked about removing brain and losing language or motor abilities, but there are other things that can happen. We also want to look at long term outcome. We heard from our colleague from Kansas City that if you wait too long to get to a non medicine intervention, you may have bad long term outcomes. And even after surgery, brain can change and develop. So we want to think about cognition. We want to think about executive functioning, and that's all the frontal lobe stuff that helps you plan a project, organize an activity, write a talk, and other things like that. We've heard a lot about language today, but also memory. And why we care about this as a child psychiatrist, for those of you who treat people during school and in university, we care about the impact on school functioning and learning and progress despite having epilepsy, including things like processing speed and psychiatric comorbidity, which we talked about earlier today. So, first, to sort of think about epilepsy medications, there are some medicines that have very little effect on cognition, things like lamotrigine, gabapentin, and levetiracetam, which doesn't change your thinking profile, if you will, or your cognitive speed. Some at higher levels, like toxic levels, carbamazepine can sometimes have that effect, phenytoin, valproic acid, and oxcarbazepine. And then the medicines that really can affect thinking and cognition, which are things like topiramate. We always used to call it, in the United States, we called it the Southern Belle drug, which meant that you were skinny and slow in your thinking and speaking, right? Word finding difficulties that you see with topiramate, and then zonisamide and phenobarbital can also affect cognition. There's a very nice review in Children by Dr. Lorino and his colleagues looking at the neuropsychological and behavioral effects of anti epilepsy drugs that was published in 2007. But these are all about processing speed and motor things and some effects on memory. Sorry, I forgot the top of the slide. Sorry about that. But we also use all of these anti epileptic drugs to help for mood stabilization. So we use lamotrigine and oxcarbon, carbamazepine, and valproic acid. We then have things that actually worsen behavior, not just thinking. So levetiracetam and I can't say it, but Brivec. And then some medicines may also cause psychosis, perampanel, which is an NMDA agonist, and zonisamide, and felbamate, which made it was the first new seizure medicine in many years in the United States. We were all excited. And whenever there's a new seizure medicine, all the psychiatrists use it for bipolar disorder. And the problem is with felbamate, sometimes you actually develop mania. And so people whose seizures were gone all of a sudden were spending lots of money and betting on the lottery and spending all kinds of things and doing stuff they would never normally do. And that's when we knew it actually precipitated mania. So we also want to think about the other sort of cognitive changes that can happen and look at long term outcome after surgery. We want to talk a little bit about psychiatric or non epileptic seizures. I'm not going to talk about SUDEP or reproductive health and risks. We will not talk about all of that. But when we start to think about epilepsy, now that we have better treatments, we then have to think about how the treatments affect the brain and what's going on. So you want to monitor people as they have more and more seizures, their cognition can change. And that's the whole purpose of early intervention, including surgical intervention. And also to help in school. Many of these are patients that have onset of epilepsy in childhood, and they're trying to go to school and they're trying to learn. 50 years ago, people with epilepsy didn't get to go to school. They were so sick they didn't have a chance to learn and be educated, and that's not true anymore. And as you're starting to think about doing surgery for a patient, you want to know what the location is. Is it going to affect memory? Is it going to affect language? Is it going to affect motor ability? And you can use the fMRIs we just heard about to prepare. And what skills, this is the most important part. If you have surgery, what are you going to lose? What abilities are going to be gone? And when do you time surgery? Do you operate early? Because we know if we operate early, language, which was on the left for your right-handed patient, can move to the other side. If you wait until they're in their teens or in their 20s to operate, as we used to do, language can't move so easily. And so when do you do everything that you have to do to help people? And also speaking with the parents and the family about the risks so they know what to expect. Because oftentimes, right after surgery, when we have swelling, you may have some loss of language or loss of motor skills. And then 6 months later, they return because the swelling is gone down postoperatively. And you want to use things like the WADA and some of the other things to map language. So, some of the domains that you may want to think about include memory, language, processing speed, and attention. Those are the four big ones that we think about in terms of learning and functioning in day-to-day life. But things like visuospatial and executive functioning, which is going to impact school, are also important. And we've talked about operating on very young children. We talked about MRIs in people less than 4 months and less than 4 years, but cognitive assessments like intelligence, if you will, really isn't well assessed until language is pretty much there and people are over the age of 40. There's no magic IQ test for a 2-year-old. There just isn't one that's accurate or very predictive. So the other thing is there an epilepsy profile? Can you just look at a person with epilepsy and say, these are the things that we're going to see on cognition? And the answer is no, because it depends on a lot of different things. One of the most important things is focal epilepsy doesn't always give you focal deficits. So if you've got a right temporal focus, that doesn't mean you maybe only have one thing wrong on your neuropsychological profile. It may be more generalized than that. And whether a person's, and I'm sorry, I'm using the old categories, and forgive me, I'm a psychiatrist, so I get a buy on that one. But having focal or generalized seizures may both impact a child's functioning across many domains, not just one. The other thing to remember is because epilepsy's been there for a shorter period of time in a child, the profiles you see in adults with epilepsy, which have been well studied in terms of cognition and memory, kids don't always follow the same profile. And one of the things to think about for severity of disease, if you're trying to figure out how bad is the impairment in functioning, is to look at the underlying pathology. Most importantly, how many times have you had status? Because think about how bad that is. If you think about ESES, where patients have status while they're asleep, those are some of the children that have some of the biggest impact on cognition from the progression of their epilepsy. And then what anti-seizure medicines people are using. This is a very busy slide, and I'm not going to spend a lot of time on it, except to say if you look over here, we're going to get a profile before surgery. You want to look at family variables including access to healthcare, which is important, treatment-related variables, how old they are at the time of evaluation, and how long after the start of seizures or seizure control is it, and then the actual seizure profile itself. And there's a nice review by Dr. Smith and Dr. Burrell going into all of this that you can look at and get a further depth on this. But the other thing to remember is many children with bad epilepsy can have intellectual disability. So a third of children will have an IQ less than 70, which is the formal definition of at least mild intellectual disability. It's higher risk factor, or people will more commonly have intellectual disability if they have a primary generalized epilepsy, if they have things like Lennox-Gastaut, although we heard earlier today not everybody with Lennox-Gastaut is profoundly impaired, and some partial epilepsies where the seizure focus is difficult to isolate. If people have volumetric abnormalities, so they've got a megaencephaly or they've had a shrunken brain, early onset, frequent seizures, people requiring polytherapy, again, as a way to sort of think more difficult to treat if you need to have 2 or 3 medications, and things like autism, where we often have intellectual disability. These are just the different kinds of epilepsies. We've talked a lot about this today, and some of the pathology. So if we think about temporal lobe epilepsy, where we have pathology in the hippocampus and the mesial temporal lobe, they have anterograde memory deficits. People with frontal lobe epilepsy have problems. We always think about this with ADHD as well. Your frontal lobe doesn't do well. You can't plan things. You have executive function issues. Or things like absence epilepsy. We've heard a lot about that today from all our colleagues. Those are the same kids that look like they have ADHD. They have problems with attention and focus. This is looking at IQ with all of the different kinds of epilepsy in general. And you will see again, as we've talked about, and blue is full scale IQ, yellow is verbal, and red is performance. But we'll see that the generalized symptomatic epilepsies have the lowest z-score below normal on IQ, and things like generalized idiopathic and central and temporal lobe have better or closer to normal IQs. This is looking at patients with, again, different kinds of epilepsy and their normal siblings on the left. So these are siblings, looking at in black language, processing speed in gray, attention in green, and memory and learning in white. So we're going to compare all our patients to their siblings. Localized idiopathic epilepsy, they do as well as their siblings do, basically. But almost all of the other epilepsies perform at lower abilities than their siblings. And this is just a really nice paper that was by Fastenau and his colleagues in 2009, comparing the siblings without epilepsy to the different subtypes of epilepsy. We've already talked about ADHD and epilepsy, but to say for ADHD, we have inattentive ADHD, hyperactive impulsive ADHD, and combined type. The most common type in people with epilepsy is actually inattentive ADHD. And that's very different than what I see clinically as a child psychiatrist, where most people are hyperactive or combined type. So if you've got someone in your office who really has mostly trouble focusing and paying attention and is not running all over the place, those were some of the kids where you might want to think a little bit more closely about getting a good history to make sure they're not having an undiagnosed seizure disorder. The presentation is at 11 to 16 with the ADHD symptoms, and we can use stimulants to treat them. There was an fMRI study that shows in patients with and without epilepsy that the response to stimulants, behaviorally and neurally, is the same. They look the same in the fMRI scanner on and off stimulants, whether you had epilepsy or not. So I thought that was kind of fun to see that they responded the same to the medication. When you think about, does the location of your epilepsy affect your ability to pay attention differently? It does. It's fascinating. So if you have a left seizure focus, you have worse attention and worse visual memory. Think about remembering maps or remembering photos for an examination, slides for histology. They'd have more trouble. People with a right focus will have worse verbal memory. So if you gave your child with a right seizure focus a grocery list, I want you to go to the store and get bread, milk, and some eggs, and they didn't write it down, it would be gone. Or remembering lists in school or vocabulary lists. And that's a big paper by Dr. Engel and Smith that's helpful to know. 69% of kids with intractable epilepsy had elevations on the brief, and the brief is a executive function assessment that looks at all kinds of domains of executive functioning. It was originally designed to evaluate children with ADHD, but it's been done in people with epilepsy as well. And there were 4 or more subscales on the brief that were elevated. The most commonly elevated scale is working memory. And again, if we go back to remembering the grocery list, working memory is what you hold in your head after hearing a talk or a lecture and try and remember for immediate recall. Because if you can't hold it in your working memory, it'll never make it to your long term memory. And this is where school becomes difficult for people with untreated epilepsy, especially. This is just all of the different executive function domains on the brief 1 and the brief 2. And again, we had that biggest difficulty with working memory, but other things are shifting. For those of you who know psychiatry, that would be like on the Wisconsin card sorter. For those of you with children, if you play Uno and you're matching on color, shape, or number, when you switch from one to the other, people with difficulty in shifting can't do that. Not so much of an issue with emotional control, so less tantruming and upset, but other ones like organization of materials. So that's getting your stuff together for a school project or a science lab. That's hard for kids with epilepsy. Language, we spent a lot of time already with Dr. Guyard's talking about this, but it's important to look at things based on seizure type, like Landau-Kleffner or Rasmussen's. And language problems are evident, but people with a frontal or temporal lobe epilepsy or the seizure focus can be present in kids. Naming difficulties, which is associated with the left temporal lobe in adults, is more evident in adults than in children. So that's one of those places where adult epilepsy patients have a different level of deficit than kids do. And that may be related to that language reorganization that we've talked about. In non intellectually disabled populations, single word knowledge, like how many animals can you name that are in the zoo, is not that impaired. For adults, there is an association between a left temporal lobe epilepsy focus and verbal memory impairments, both before and after surgery, but it's not a very strong one. Children with epilepsy have deficits in memory, but it's not a very specific pattern as it is in adults. When we have adults, the majority of studies don't show pre-surgical lateralization of memory impairment. Verbal memory can be affected in children and in pediatric patients as well, and the references are all at the bottom of the page. when we look post-operatively, is there a decline in memory? 4 out of 13 show a decline. 6 out of 13 studies showed no change in memory before and after surgery. And 3 out of 13 showed an improvement. And if you think about, again, if we think about encoding, if the seizures stop, then you have the ability to encode, and that may be one of the reasons that memory improves after surgery. There are a lot of different studies that, again, didn't always look at what structures were specifically removed to then correlate with memory. We've paid more attention to this as time has gone on, and the group means and reliable changes were there. I'm going to show you. Processing speed is also an issue. And again, processing speed is what allows you to keep up in the classroom. So if you think about, most of you in this audience did not grow up speaking English. And one of the abilities that's important for listening to a lecture like this is your processing speed, your ability to hear in a language that you don't speak every day, listen to it, understand it, and remember part of it. And if your processing speed is slow, it's harder to do all of that as we change from slide to slide. So, one of the risk factors for slowing down your processing speed is the number of anti-seizure medications that you're taking, the type of anti-seizure medication again. So, topiramate and phenobarbital actually sort of slow down your processing speed irregardless of your epilepsy type. And then having a frontal lobe or ESES type of epilepsy can also lead to lower processing speed. But 30% of kids with focal unaware seizures have impairment not in processing speed, but in motor skills. So that's important when you're doing things like riding a bicycle or walking across the street, because if you need to stop quickly, they can't. And that sometimes leads to very bad things. When we look at academic functioning, this is a study that came out in 2004, again by Fastineau, looking at all the different epilepsy types and sort of looking at an average score, if you will, of 100, just like a full scale IQ score, and looking at all of the different types of issues, including language. The first several are language, phonological awareness, naming, decoding, all the stuff you need to speak and learn. They're all below normal, and some of them are statistically significant. So anything that's got a asterisk or the statistically significant impairments with epilepsy. We talked a bit earlier about autism. We certainly have an increased prevalence of seizures in youth with autism. They have abnormal EEGs. 10% of patients with autism will actually meet the diagnostic criteria for epilepsy, but 40 to 60% will have an abnormal EEG. We already heard today that you don't treat the abnormal EEG, you treat when people have seizures. But people with tuberous sclerosis, Dravet's also have a higher rate of autism, so they're even higher risk of having things like intellectual disability. We talked a bit about comorbidity, but there are higher levels of epilepsy in people with a number of different psychiatric and other neurologic disorders. Some of these comorbidities may show up soon before or after the onset of seizure. Somebody was talking earlier today, actually, I think it was yesterday, about that was MS. Sorry, I'm very bad. But in MS, people sometimes have depression or anxiety first and then the onset of MS. There are some papers that actually show in young children before the onset of the first clinically detectable seizure, they may have mood changes such as depression or anxiety. So if you think about it as a common shared neurologic vulnerability, if you will, some people will have the psychiatric manifestations before the obvious seizure. So it's important when people come to the child psychiatrist for things like ADD and depression to make sure there's nothing else going on. When they looked in a large review study in 2015 of 20 other patients, 12 out of 20 showed a decline in neuropsychological functioning over time. 5 out of the 20 studies had mixed results. Some things got better, some things didn't. And 3 out of 20 had no relationship between neuropsychological function and epilepsy over time. Things that were more likely to lead to a decline in functioning included, again, that ongoing or greater number of seizures, the side of the seizure focus. So left was more likely because language is based there, right? More likely to have a lower level of functioning over time, other comorbid disorders, and missing school due to disease and medical management. So if you're sick because you're going to the hospital once every 2 months for status, you're going to miss school. And if children in Egypt are like children in the United States, parents are scared to send their children to school with epilepsy. We have to have management plans. When we have a child with epilepsy and they go to school, we have to have a specific emergency plan for the teachers and the school nurse, or they don't want the children coming to school. And then if you don't go to school, you can't learn. So there's the whole interaction that goes back and forth. You can have declines in IQ over time, but it really depends on the type of seizure. If people seem to be losing cognitive capacity, you always want to make sure you're not toxic on your drug levels, because sometimes people can have mental slowing and word finding difficulties and things like that, not because the seizures are removing brain capacity, but because their level of medication is too high. Sometimes it's a drug-drug interaction thing. And repeated status, which also can be associated with anoxia, can drop the IQ. I've got 2 minutes left, so I'm going to skip around and look at some of the long-term outcome studies, because I think that's the other thing that's important. So there was a large group that came out in 2011, 42 children who had surgery between 92 and 2002. 18 of them didn't come back for follow-up. The majority, 62%, had hippocampal sclerosis, and 60% had a left-sided focus. And there were 11 kids in the control group who were evaluated for surgery but didn't have it. They also, 45% had hippocampal sclerosis. They followed them out for about 9 years. And at surgery, they were on average early teenagers, 13 years old. At follow-up, they're 22, so they're university age, if you will. Seizure-free, 86% of the kids with surgery versus 36 for non-surgical. And still taking medication, anti-epilepsy drugs, 43% of kids after surgery still were on drugs versus 73% who didn't. And what they found was that baseline is in white and long-term follow-up is in black. So baseline IQs were lower for many of the patients, and after surgery, we had people who were normal or close to normal IQ and even some higher IQ levels. In general, what happened is before surgery and after surgery, the full scale IQ went up. Their IQ went up. And that's really important as a teenager to a young adult to have an improvement in your IQ, whereas the control people didn't change dramatically. These are the same people with epilepsy, but they didn't have surgery. And so I think that's helpful when you're talking to a parent, because the thing parents worry about the most is if you take out part of my child's brain, are you going to damage their intelligence? And what we see from this paper is, in fact, there's a chance that they may even get a little bit smarter, not dramatically so, but we're taking away some of the medicines, the seizures are stopping, and that's a good thing to be able to tell families. For at the bottom here, 41% improved the IQ by 10 points. That's one standard deviation. That's not bad. Because I think, again, many people are reluctant to have surgery, especially early on. They're like, I'm just going to wait for the medicine to work. And this is, again, looking, it doesn't like me anymore. It died. I ran out of time, didn't I? I touched nothing. Yeah, we'll just look at this and then I'll be done. Okay, thank you. This is my last slide. So, one of the things is people with right-sided surgery tended on their verbal IQ and their performance IQ to have much better performance IQ after surgery. And for the left-sided people, the verbal IQ was higher. But the other thing is time after surgery, and this is also important when you're speaking with parents. As you go from the first 2 years to the next 2 years, right? So this is finishing high school and this is going on to university. You continue to have improvement over time in the IQ. And again, I think this is really important because parents may say, you did surgery on my child, they've woken up, the seizures are gone, but they're not doing any better in school. To be able to speak to parents and say, we see improvement, but improvement takes time for the brain to heal is also an important part about the hope that we can give families when we're talking about treatment after surgery. And they talked about being able to stop anti-seizure medicine was one of the ways that they had improvement. So I'm going to stop so that we can get to the rest of the talk. There's another set, and we are happy to share slides of another large group that looked at post-surgical outcomes, but they're very similar to this. And I think it's just important to know that surgery can make a difference. And I am not a neurosurgeon, I promise. All right. Thank you.